Hi, Melanie.
Hi,
Welcome.
Sarah.
Thank you so much for doing this.
Yeah, I'm glad to finally give us the CSD seminar talk.
I'm so glad to hear about your work. I'm going to turn my picture on because I haven't eaten my lunch yet. But thank you, Maria, too, for everything. You're on mute. Happy New Year. You're still on mute.
Happy New Year to you.
Okay, on that note, it's time to get started. We're kind of slowly still just trickling in. So welcome, it's winter quarter. We made it so far. So we have an excellent schedule this term of speakers, so please go online and take a look. Also a couple of excellent panels and our lightning talk and poster session. So we hope to see you ongoing through the whole term. So today I have the pleasure of welcoming Dr. Melanie Martin, and I'll tell you just a little bit about her and then let her get started. She is an assistant professor of biological anthropology here at the University of Washington. She's also a CSDE affiliate. Her work focuses on studying biocultural influences on growth, development, and reproduction in a variety of areas in maternal and child health. She has conducted extremely interesting work in community engaged contexts with indigenous families in northern Argentina, which she'll be talking about some today, as well as in the Bolivian Amazon. She's also currently conducting a study locally examining COVID-19 risks and immune responses in mother-infant dyads. So we're so excited to have you and to learn more about your work today in your talk. And your talk is entitled Cesarean Birth and Infant Health and Breastfeeding Outcomes in a Marginalized Indigenous Community in Argentina, Risk Pathways and Local Contexts. And so I'll just reiterate our system for people who are new this term. So please use the Q&A function at the bottom. So we prefer this over chat. So if you want to go ahead and just put your questions in as you think of them, or you can just say you have a question, that's fine too. And then at the end, we'll go through those and manage them together. And I'll explain that I have a list and I can see your name in that list. And if I click on it, it gives you the ability to unmute yourself. And in that way, you can ask your own question or you can follow up or have more of a discussion. So we can do that. And if you don't want to do that, that's fine too. We'll read your question and you can also ask questions anonymously. So on that note, thanks again, Dr. Martin. I will let you take it from here.
Thank you, Maria, and everybody at CSDE and all of you out in the void. I'm happy to be speaking to you all today about my work. And I want to start off by acknowledging that this is some collaborative research that I'm going to be presenting today. So I want to give those acknowledgements first. First to my colleague, co-investigator, Professor Claudia Valacia at Yale University, who founded and is the director of the Chaco Area Reproductive Ecology Project, from which this data that I'm presenting on today was collected. Our field coordinator down in Argentina, Sofia Olmedo, and all of our research assistants in the communities and all of the families in the communities that we work with, along with Fundación ECHO for providing logistical support, funding from the National Science Foundation. And then here at the University of Washington, the Department of Anthropology, collaborators who have worked on some of this work with me, my postdoctoral assistant, Monica Keith, as well as some graduate and undergraduate students who've worked on part of this previously, Anesha Pan, Deja Edwards, and Alicia Barrientos. So I'll start off by discussing the fact that there is a global epidemic of increasing cesarean sections that we've seen in the last few decades, as was the subject of this 2018 Lancet special issue. It has been estimated that only about 10 to 15% of cesareans are medically necessary to save maternal or fetal life, but globally we see that about 20% of births are cesarean deliveries, and that may not seem like a huge difference, but that rate is double what it was in 2000. And there's also a lot of wide variation within and across countries. So for example, cesarean rates are as low as 5% in some areas of sub-Saharan Africa and over 50% in areas of Europe, Asia, the Middle East, and South America. And cesarean sections are major surgery, and so any increase in medically unnecessary cesareans can increase health risks for mothers and infants. And that can happen through a variety of pathways. And what we see in the short term is that cesarean delivery is associated with increased maternal morbidity and mortality due to complications that can arise from anesthesia, bleeding, and infection. We also see that non-spontaneous preterm cesarean delivery is associated with increased risk of neonatal respiratory morbidity. Long term, it is also proposed that there's also been observed increased risk for subsequent pregnancies, which arise from spontaneous preterm birth, uterine rupture, and abnormal placentation. And cesarean section may also increase infants' risks of later life chronic immune and metabolic disorders, including asthma, allergy, obesity, and inflammatory bowel disease. Now, evidence for the latter, which is really what I'll be talking about today, has been mixed, and that may in part relate to the confounding pathways by which cesarean delivery is associated with later health outcomes. So I'm going to review some of these. Directly, cesarean delivery can alter the fetal and neonatal hormonal microbial exposures, and that can lead to altered infant microbial development, and which then alters infant immune and metabolic development and regulation. Cesarean delivery can also delay maternal infant contact and bonding, which delays breastfeeding initiation, and further interfere with the hormonal pathways that regulate the onset of mature milk production. So those breastfeeding difficulties in the immediate postpartum period can then require earlier supplementation or increased supplementation. And what all that results in then is increased risk of acute and chronic health disorders, as well as earlier weaning, whether we're talking about weaning before the mother desires it or before as currently recommended. So current recommendations for optimal breastfeeding practices are 6 months of exclusive breastfeeding and 1 to 2 years of breastfeeding, depending on whose recommendations you're going off of. However, cesarean delivery also co-occurs and is often the consequence of many underlying maternal and fetal risk factors. So these are the indirect pathways by which cesarean section can be associated with later life health risks. So these underlying risk factors can include primiparity, adolescent age or advanced maternal age, maternal obesity, undernutrition, gestational diabetes, hypertension, stress, preeclampsia, fetal intrauterine growth restriction, and fetal macrosomia. And these underlying risk factors are often themselves the result of socio-structural factors that are going to persist into the postnatal period. And so infant health risks are going to be continue to be affected by these throughout their development. Factors like preterm birth and maternal obesity or diabetes can also increase the likelihood of breastfeeding difficulties due to impaired latch or insufficient milk production. And so again, we get the end result that cesarean delivery is associated with later life acute and chronic health disorders, as well as earlier weaning. Now, currently, the average rate of cesarean delivery in Latin America and the Caribbean is 44%, which is the highest regional average globally. And this may be compounded for many indigenous populations as the continued effects of colonization, racism, and economic marginalization increase maternal and fetal gestational risks. The higher cesarean rates that they are experiencing in turn may increase their susceptibility to chronic disease for future generations. Now, for many Latin American indigenous populations, the transition to biomedical modes of prenatal care and birth have been relatively recent and often forced, while rural communities in particular experience dual burdens of high infectious disease and increasing rates of chronic disease. However, many Latin American indigenous populations maintain traditional prenatal birth and infant care and feeding practices, which may also protect them against those higher rates of medically unnecessary cesarean section and related adverse outcomes. Therefore, to promote better informed birthing decisions and policies, more research from diverse settings is needed to examine the range of factors associated with cesarean delivery and possible long-term consequences within specific contexts. So this brings me to the research that I'm presenting today, which was conducted with a peri-urban indigenous community in rural Argentina. I'm going to first present some published work which was motivated by the fact that most studies of cesarean-associated infant risks have focused on the acute neonatal morbidity risks as well as later chronic disease risks. We wanted to test if cesareans were associated with greater risk of infectious illness throughout infancy in a high infectious disease environment. We then wanted to test if cesarean section would be associated with adverse breastfeeding outcomes in this population that has strong traditional support for breastfeeding. And so I'll present some of that work as well, which is from a manuscript in prep. So I mentioned this research was done with an indigenous group. These are Com families and from a peri-urban community of about 5,000 people in the northeastern Formosa province. Formosa is one of the more rural and most underdeveloped provinces in Argentina. Families in this particular community over the last century were forced by government policy and environmental degradation into an unincorporated community outside of the Formosa capital called Namcon. Families in this community live in a mix of government constructed homes and self-constructed mud brick dwellings. There is potable water, but also ditch drainage and dirt roads and no trash services. Free healthcare is provided at a clinic within the community, but families also report frequent viral, gastrointestinal, and respiratory illnesses, which are likely due to relatively poor hygiene, zoonotic exposures, mosquito-borne illnesses, and wood fires used for heat and cooking. Now, we have previously described the Com as a traditionally intensive breastfeeding population, meaning that in this population, as has been documented over the last 20 years, breastfeeding is nearly universal. Mothers exclusively breastfeed for about 6 months on average. So that means they're introducing other foods around 6 months of age, and they continue to breastfeed for around 2 years on average. There is some bottle feeding, but generally with powdered milk because formula is really economically unfeasible for most families. The data that I'm presenting today was originally collected by CARE project researchers from 2011 to 2014 for a study on early life transitions. Throughout the study, CARE researchers visited participants in their home monthly to collect anthropometric measures, as demonstrated here, as well as data on illness symptoms and feeding practices. Birth mode and gestational risk factors were collected opportunistically from birth records that were maintained at the community health center and then shared with consent by participants. In total, there were complete or partially complete records for 91 of the 101 infants in the sample. Now, in this sample, mentioned that this research was previously published. And in this paper, we examined both the factors that were associated with cesarean delivery in this sample, as well as the relationship between cesarean delivery and infectious illness risk. So 97% of the mothers in this sample gave birth at an urban hospital. So this is a public hospital in Formosa. So they all gave birth at the same hospital. On average, from available records, mothers had 6 prenatal visits, and birth weight and gestational age in this sample are comparable to those we see in reports from the US and Europe. We did, in the sample, there were 4 low birth weight babies, 3 macrosomatic babies, and 7 babies that would be classified as small for gestational age. Now, within the sample, 46% of deliveries were cesarean deliveries, so comparable to that overall Latin American statistic, and also very indicative of the fact that a large proportion of these cesarean sections are probably medically unnecessary. Only 4 of the 42 records for cesarean delivered infants indicated any explicit reason for the surgery. 3 were related to fetal position and 1 because of a previous cesarean. Birth records did not state whether cesareans had been scheduled or unscheduled cesareans, and only 13 records noted any other complications that could have been an indication for the cesarean, including gestational hypertension, fetal distress, and premature birth. There were no differences in mean birth weight or APGAR scores among cesarean or vaginally delivered infants, and the macrosomatic low birth weight and small for gestational age infants were a mix of both cesarean and vaginal births. We did observe a higher rate of cesarean deliveries among mothers who were younger than 20, as well as older than 30. And this may conversely rate higher rates of scheduled cesarean, either because physicians determined risks for higher risks for adolescent pregnancy, or they were warranted due to previous cesareans in the case of the older moms. Birth weight was not associated with cesarean, but adolescent mothers and moms over 30 did have lower birth weight babies on average. And then we did see a higher rate of cesarean among early and preterm delivered babies. Now, I said we don't know from records whether cesareans were scheduled or unscheduled, but we are confident that CALM mothers do not choose elective cesareans. And this is because of both reported abuses that they have told us about and general mistrust of the medical system, as well as reported discomfort with cesareans, as illustrated by this quote from a 33-year-old mother. "My last birth was a very bad experience. Think about going from a normal birth to a cesarean. It's something very different. A normal birth, you have your baby and right away you can get up and do your things. But with a cesarean, no. You always have to be dependent on whoever you can help, whoever it is at your side, no?" And so I want to stress here that the discomfort with cesarean is not like we observe typically in the US, where cesarean deliveries might not be the outcome that mothers wanted if they were hoping for an unmedicated vaginal birth, but pertains instead to pain during recovery and the dependency that they have on others in recovery. Okay, so I'm gonna now present the data on risks of infant infectious illness related to cesarean. And for this, our sample included 90 subjects with complete data for all outcomes and predictors, and 1,948 observations total across the sample. We ran I'm gonna start here. Across all observations, gastrointestinal and respiratory illness symptoms were reported by the mother for their baby at any point in the last month. So this was the outcome that we used 72% of the time. Then we further broke that apart separately for gastrointestinal and respiratory symptoms. And gastrointestinal symptoms were observed across all observations 31% of the time, and respiratory symptoms observed across all observations 63% of the time. Or sorry, I should say reported 63% of the time. And I'll start here. So I ran a mixed effects logistic regression with a random slope and intercept for child age and ID. And I started with a baseline model that included just whether the infant was currently breastfeeding or not and weight for HC scores. And so here in the baseline model, running separate models for gastrointestinal risk and respiratory illness risk, we observed a reduced risk of gastrointestinal illness with greater weight for age, which is expected, suggesting those infants are either buffered against gastrointestinal illness, or the opposite can occur with gastrointestinal illness resulting in temporary decreases in weight that would look like lower weight for age. So that was expected. But we unexpectedly observed then a reduced risk of gastrointestinal illness for infants who are not breastfeeding at the time of observation. Now, to this baseline model then, we added additional gestational and maternal risk factors. So whether the infant was preterm or early term as compared to full term, so greater than 39 weeks, and maternal adolescent age or a more advanced age of 30 to 35 as compared to 20 to 29 years. And when we added in those, we observed a significantly reduced risk of gastrointestinal illness for older mothers. And we observed a reduced risk of respiratory illness for early term and preterm infants. So definitely not what we expected there. And then lastly, we added in cesarean section to observe for both direct effects of cesarean section, as well as any moderating effects on other variables. And here we observed no effect, no relationship between cesarean section and gastrointestinal illness, no moderating effects on other variables. We did observe some moderating effects with pre and early term birth, and then completely unexpectedly, a reduced risk of respiratory illness for infants that had been delivered via cesarean. So I'm going to come back to that at the end in a summary conclusion, and then move on to the work that we're currently preparing for publication related to cesarean section and breastfeeding outcomes. So we first modeled time to complementary feeding and time to weaning using a Gompertz distribution that accounted for both interval and left and right censoring. And our median time to complementary feeding was 23 weeks. So, around five and a half months, and median time to weaning around 30 months, so around 2.5 years. And so this is consistent with work that had been done, almost 20 years ago, suggesting that breastfeeding patterns really haven't changed recently in recent decades. And we next modeled whether time to complementary feeding and time to weaning separately varied with cesarean or vaginal births, further adjusting for infant sex. And then because of confounding between cesarean section, maternal age, primiparity, gestational age, and birth weight, for those models, we selected best models based on leave one out cross-validation and WIC, as we had no a priori predictions about which of the confounding factors would be the more driving factor. So first, looking at the model of time to complementary feeding, this is a forest plot of time to complementary feeding showing the mean of model posterior distribution of the hazard ratio for each factor, and then 95% Bayesian credible intervals. And all the coefficient variables from the full time to complementary feeding models posterior distribution span 0, all the hazard ratio intervals span 1, indicating that these modeled parameters neither consistently increase nor decrease the age at which COLM infants begin consuming complementary foods. So none of our factors seem to be related to exclusive breastfeeding duration, age at complementary feeding. For time to weaning, conversely, we observed a higher hazard for early to preterm delivered babies, so babies born before 39 weeks as compared to babies born after 39 weeks, and a lower hazard for males and cesarean-born infants. So meaning cesarean-born infants were weaned later, contrary to what we would predict. So putting this all together, at a minimum, we can say that in this community, contrary to our expectations, cesarean section was not associated with any increased infectious disease risk or any increased risk of adverse breastfeeding outcomes. But of course, these findings really raise more questions than answers. And two very counterintuitive findings within this fly against much comparative research. We observed in the morbidity analysis that preterm birth and not breastfeeding were associated with both reduced odds of gastrointestinal illness and respiratory illness. We also observed that males were weaned later, and across many different populations, it has been observed that, biologically that males grow faster, and across populations, males tend to be weaned earlier, which has often been interpreted as a maternal response to the increased demand presented by males to breastfeed more. So it's possible, first off, that the preterm and cesarean-born infants in our sample were growing more rapidly due to catch-up growth. And this may actually have reduced their risk of infectious illness through fat buffering. Importantly, though, if this is the case, it would then seem that the rapid catch-up growth would not be related to earlier weaning, as is what has been proposed with males and earlier weaning. We also think that here the context of breastfeeding among the COM is particularly relevant, both how breastfeeding is practiced and valued. Anecdotally, some COM moms have reported that they perceive males as needier, and our analysis shows that males are weaned later. So this coincides with ongoing research that my field coordinator is doing, showing that mothers really report continuing to breastfeed their babies after infancy, so into age 2, 3, or 4, largely because they perceive them as needing additional nurturing, not because they're perceived as needed additional energy provided by breast milk, but only through nurturing in the psychological and emotional sense. So this also may explain the relationship between later weaning observed for cesarean-born infants. It's possible that if cesarean deliveries in this population are related to birth and gestational risk factors, as well as more rapid growth, that mothers continue to breastfeed their cesarean delivered infants longer because they perceive that they are more vulnerable or they need more nurturing and care. They're not responding to that perceived additional need for nurturing care by weaning, as has been proposed for many other populations. And that is very likely because this is a culture that highly values the nurturing aspects of breastfeeding after infancy. Now, importantly, I want to add here that although we didn't observe any effect of cesarean on time to complementary feeding, which could be suggestive of early problems with breastfeeding, those results shouldn't be taken to indicate that mothers who deliver via cesarean don't have any breastfeeding problems at all, or that breastfeeding problems experienced by mothers who deliver via cesarean in other contexts are not real. One, we just lack the data to discuss it. But also that, I think more importantly, it may be suggestive of the postpartum period being more important in the breastfeeding outcomes for COM mothers than what they experience in the immediate postpartum period. And this is due both to their own culture and the unique situation of the hospital that they give birth in. So this hospital is a public hospital with low resources. mothers don't come to the hospital to spend a lot of time there. There aren't nurseries. Mothers are actually, once they give birth, they're in group rooms with maybe 6 to 8 women per room, and their infants are always right next to them. So because of a lack of resources, it actually facilitates more maternal infant contact in the postpartum, whether cesarean or not, except in the case of preterm birth, in which there is a NICU unit. And then once they are at home, the context of breastfeeding among the NAMCOM community and other COM populations is one that is very supportive of intensive breastfeeding. There are no barriers to breastfeeding. Mothers aren't working outside the home. They maintain contact with their infants constantly. Breastfeeding is open. It's not taboo. They sleep with their infants overnight. And again, prolonged breastfeeding is also supported and valued because of the nurturing aspect of it. So this is all not to say that this is a context which I think should or can be easily replicated in other environments where we do observe an association between cesarean birth and breastfeeding problems, shorter breastfeeding duration, earlier weaning, but rather that we need more emphasis on the social and socio-structural supports for breastfeeding beyond that immediate postpartum period outside of the hospital. And right now, nearly all of our energies in this country and many other high resource countries are really directed at support during that immediate postpartum period in the hospital and with lactational consultants that can only visit moms for very brief periods of time in the hospital or possibly in the first few weeks postpartum. So this is all to say that we need more research, but not just more research in general. But I think in investigating the relationship between cesarean birth and adverse breastfeeding or health outcomes, more research that explicitly separates out those risks by both the direct and indirect pathways and in the immediate postpartum period and then beyond through later infancy and even beyond that. So with the research that we have collected and some follow-up research that we collected a couple years ago, we're hoping to begin to explore a little bit more of this. First off, Monica and I are analyzing existing growth data to actually test whether cesarean-born infants in this sample do experience more rapid growth or catch-up growth. We also did a follow-up study with about 60 of the infants that had been in this study that we were able to recontact at the ages between ages 7 and 9. So we'll ultimately then test if those if those infant growth trajectories map on to growth outcomes in mid-childhood. And therefore, if there's any relationship between cesarean birth and rapid infant growth, if that persists into mid-childhood. We're also looking more into COM mothers' birth and breastfeeding experiences. So as most of this data was done, it was a secondary data analysis of birth records that were shared and copied opportunistically. There weren't necessarily data to go with that about the mom's experiences during birth, especially if it was a cesarean birth and their breastfeeding experiences. We did, in that same follow-up that we were able to contact about 60 moms, ask them about their breastfeeding experiences with their first child, as well as the child that was part of that study, in case they were not primiparous moms. And interestingly, I didn't present it here, but moms have said that many moms do report a lot of pain and difficulties with their first child, much more than we had anticipated. But they're all helped by, importantly, their mothers and other family members, and so seem to get the support they need to get past that difficulty. And very few reported any problems with the infant that was not part, with the infant that was part of the study for mothers who were not first-time moms. And then ultimately, we hope to conduct a larger study, a larger prospective study or retrospective study with all mothers who are delivering at this public hospital, because that public hospital serves all mothers in the Formosa capital who only have access to government provided healthcare. And so that includes the Com families and other ethnicities, as well as other Argentinian nationals. And we have partnered with the lactation program at the hospital to hopefully, once we're able to get back into the field, to study across moms birth and breastfeeding outcomes related to both their hospital experiences, birth mode, and then the postpartum social support network. So that is all I have. And thank you all for watching and listening. And I'm happy to take any questions.
Thank you so much, Melanie. That was great. I think we do have a question in chat. Do you see that? I think maybe if you could read that, that would be great.
I'm not, okay, I just have to stop sharing. Yes, I have a question in chat. First question was, is there an additional cost associated with cesarean section versus natural delivery? And what was the SES for babies delivered via cesarean section or vaginal delivery? So yeah, in this sample, so all of the moms in the sample are giving birth at a public hospital, and they all receive free health care. I don't know about the financial incentives for the hospital, but it has been reported elsewhere pretty commonly that physicians are financially incentivized to perform cesarean sections because the hospital or insurance reimburses them at a greater, at a higher rate for surgical intervention than for delivery. And because we don't know what the cesarean rate in the hospital as a whole, or for non-com mothers who are delivering there, I can't say if it's a specific, if that high cesarean rate is specific to them. But it wouldn't be, there's nothing that they personally are able to affect the cost of it, because they're all getting public health insurance and they're all delivering at that same hospital. As far as income, the differences in income, we don't have the exact data, but it's pretty minimal within this community. So most families in this community live off of government, basically government welfare. Some families do supplement their income a little bit. Mothers are able to, some mothers are, artisans, and they can sell artisanal goods in town. Some families have, husbands or spouses might work outside the home, do some labor when they can. And a lot of families will forage in a local landfill for goods that they can consume or sell. So they kind of supplement their income, but there's very little, we don't see the type of variability in income, socioeconomic status that we would see in the US, or even compared in this community to other to other Argentinian nationals that live in Formosa. So this relates to what I hope to do in the future, because there I expect to see a lot more variability in both socioeconomic status, which is going to influence health risk factors, as well as support and attitudes for breastfeeding.
So we do have a question from Dan Eisenberg. He's, I did click, so if you want to unmute Dan and ask your question,
can you hear me?
read it. Super.
So yeah, I'm going to try to squeeze in two questions here if you let me. So both of them are about the breastfeeding results, which are intriguing. So one was that you had, if I understood correctly, you have increased breastfeeding predicting increased risk of infection in the contrary kind of direction that we'd expect.
Mm-hmm.
And so I'm curious if I don't think you speculated very much on why that could be, if maybe there's some sort of confounder there or something like that. And I'm curious if you have any thoughts on that.
Yeah, so what I had, when in the paper, what I discussed is, I mean, we didn't observe, in the paper, what I discussed is that it's if cesarean, because we observed a reduced effect of illness for both cesarean, at least for respiratory illness, for cesarean delivery, and reduced effect of illness for preterm birth as well in GI and respiratory illness, which I completely would not ever be expected. And so if these are all they are interrelated, if they're all interrelated in this sample, it's possible that cesarean born infants go through catch-up growth. And if that's the case, they might be weaning earlier. And so this is what I originally thought, that they might be weaning earlier. And that would explain that relationship, that, you know, in that sample, because we were only looking not at breastfeeding duration, but just whether or not the infant was breastfeeding at that moment. And so that could reflect the fact that the infants that had gotten bigger, which is more common with preterm birth and more common with cesarean birth, had already been weaned. Now, then the breastfeeding analysis we've done, though, kind of suggests the opposite, though, if that is the case. So it's really dependent on the next step in which we can integrate the growth data and see what the relationship is between birth mode, growth, and feeding transitions.
Okay, yeah, that makes sense. Can I try to sneak in another question, or should I let someone else go? Okay, I'll take that as permission to
Yeah, no, go ahead.
So the other thing is, if I'm understanding correctly, you think that males are being breastfed longer for the kind of caring benefit of the non-nutritional benefits. And would this lead, if this is true, would that lead to different predictions about breastfeeding patterns of maybe shorter bouts or different times of day or something like that, if it's not about the nutrition, or maybe even if the mom can report how much the baby is actually even suckling and getting milk? Or I'm not, as someone who hasn't breastfed myself, I'm less sure about that, but I wonder if it could lead to some of the predictions like that.
Yeah, that's a good question. I mean, I wouldn't be able to test that with this data we have, but something that I definitely like to look into more. I can't say for sure with the comb, but with my research with the where I worked previously in Bolivia, moms there, which is similarly a population that they breastfeed on demand, it's universal breastfeeding, and breastfeeding is typically very prolonged, and their weaning trajectory is the exact opposite of what happens in a country like ours, where even mothers who have all intentions for breastfeeding for a long period of time, they will usually wean at night first and only breastfeed during the day. And that's in part because of how we sleep and our expectations of how we sleep. Whereas Chomani mothers report, the population I work with in Bolivia report the exact opposite, that they'll wean, they will stop breastfeeding during the day, but continue to breastfeed at night. And so I would be interested to know if that's the same here, and if that is something that's more indicative of kind of nurturing than, you know, nutritive related breastfeeding. I think it would be hard to try and interpret frequency, because it's very possible, one, mothers who really are nursing on demand these are not moms who have a phone app that they're keeping track of how often they breastfeed, or, really keeping track at all. But also that even if it's more kind of nurturing, you might have lots more frequent bouts where they're just allowing, an older infant especially to run up and nurse for a little bit and then leave.
Thanks.
Oh, there was a question from Kieran. Question, out of curiosity, do you know how common each of the two outcomes were in the sample? I was interested in whether sample size could have played a role in explaining some of the possibly counterintuitive findings. So in terms of the illness, for the illness outcomes, yeah, respiratory illness in particular is very common, and more common than gastrointestinal illness, so across all observations, but that wasn't broken down by, we adjusted for infant ID, but I didn't try and kind of descriptively break down those differences. As far as the, outcomes for complementary feeding and weaning, I can say some things like the survival analysis, which is taking into account, interval censoring, and so infants, or we don't know they're exactly when they transitioned, or maybe what their final age of weaning was. Still, there was pretty much agreement between those infants that we observed a transition and then the overall survival analysis that we noted. And then especially because the breastfeeding data here is pretty consistent with what was observed 20 years ago. We think that yes, it is very common that that on average infants are exclusively breastfed for about 6 months and then breastfed for at least 2 years. But I can say there is definitely variation in terms of in that 6 months, right? There are a good number of infants that are starting to complementary feed fairly early on within the first few months. And the later infancy, breastfeeding in later infancy is really skewed by a handful of infants. So it's not that really, most infants are kind of weaned by around 2 years, but there's a smaller number that continue to breastfeed. And that is also might be the effect of the males, which I didn't show it here, but seems to be the case, that the male effect might actually be driven by the infants that are continuing to breastfeed up to 3 years and beyond. And so definitely, I think a bigger sample would be needed to tease some of that out. It is a small sample and there is some variation. And so there definitely could be some confounding there.
So Karen, if you wanted to follow up, you should be able to talk. I clicked on you.
Thanks so much. I have some background noise, so I was trying not to be too bad about that. Yeah, thanks so much. This is mostly a new area to me. I just thought that would be, I'm always just thinking about sample size and studies. Thanks, I think you addressed that quite well.
Okay, super. So it looks like Steve has a question.
I then mostly asked, I think it's already been answered. But I was great. It was a great talk and fascinating. And I mean, I was just interested in more on the counterintuitive findings about timing of full weaning and cesarean section. But I think you kind of pieced together all the different, how there's many confoundings in the growth trajectories, and there's more work to be done. But if there's any more pondering, any more thoughts you have on it, you want to share that?
Well, I didn't discuss also why I think that there's no effect that or no relationship we observed with anything and time to complementary feeding, which we are using as a proxy of early breastfeeding problems, right? With the understanding that if you're having breastfeeding problems early on, whether it's hormonally related or latch or developmental related, that is going to require earlier supplementation and increased supplementation. Even though this is a monthly recall that we're given to moms, if the more frequent an infant is supplementing, the more likely that the research assistants would have picked that up. But it's a very crude, I think, point I'm trying to make here though is just whether we're modeling the age at which we really are likely to observe or observe that a mom has reported that yes, yesterday I gave my baby something to eat, or I gave my baby a bottle, because we were using the definition that's used by the WHO that anything other than breast milk, so formula or milk or anything like that, is not exclusive breastfeeding. But in a population where breastfeeding is really along a continuum, it's really not. I think it's not very biologically meaningful when we try and say a transition is like an observed or a reported instance of feeding. We need some greater, more fine-tuned way of understanding kind of the relative contribution of breastfeeding and other foods and liquids to the infant diet. And there we might see a stronger, if we were modeling it that way, we might then really be able to see if there are these connections between birth mode or birth complications, and then how the infant is being fed, and then how that might relate to later growth and breastfeeding trajectories. So it's all a bit crude with what we have, but certainly motivates what the type of research that I want to do that is more that can get at this level of detail to really tease apart these pathways, because there's not only are there direct and indirect pathways, but there's all of this confounding and pathways that feed back on each other and reinforce one another. So it really requires a large sample size on one hand, but also a lot more detail over time.
I don't see a question. I have a question though, if you don't mind.
Yeah.
I may have addressed this, but I sort of missed at the beginning about how representative this group is of the community, because it sounded like they were living in a quite rural, isolated area, but the hospital was in a more metropolitan area. So I'm wondering how they got there, and if there are some that do have reverse or something in between, and whether it could mean that if they got there, that maybe they were scheduled, and maybe if they're scheduled, then the confound of C-section was less of an issue because they didn't have a C-section because of problem per se. So that's a bit of extrapolation, but I guess my basic question is just how representative the group is.
Yeah, they're representative of the community, because all families in the community were approached who had an infant under the age of 1. So I don't know the exact representation, but it's pretty representative of the community. That community though is not representative of mom's experiences or of like other mothers who are giving birth at the hospital. And there is definitely an issue of how the co-mothers are treated in the health clinic and in the hospital. It's very paternalistic. They're subject to a lot of racism in town. So it's not a big metropolitan, the city of Formosa is not a big metropolitan area. It's a sprawl kind of rural city. There are about 100,000 residents overall. And where the community is, NAMCOM community is, I mean, it's really just like a kilometer outside of the city, but unfortunately they just, they experience so much racism. Families that go into town are told, you know, you can't walk around the plaza, things like that. So they don't tend to, you know, intermingle in town. If they have to go to town, it's to go to a store, it's to go to a bank and to leave. And so they, within the hospital, within the medical system, it is certainly plausible and likely that they, you know, from what moms tell us and kind of what we know happens elsewhere, that they are, you know, they're subjected to, you know, so they might be given scheduled cesareans, but they, you know, they don't have the education of biomedical knowledge to understand what their risks and options are. And they also may be, you know, subjected to unnecessary cesareans because doctors honestly don't want to deal with it.
Okay,
The converse might
thank you.
happen too, in which with it,
How are you?
where, you know, doctors might also think that they are, you know, better able to tolerate pain or tolerate vaginal births or not give them other assistance. So we don't really know. I can say from the interviews that we have done with the moms we've recontacted, you know, we see kind of things that are all over the place where some moms say, oh, I was told that I had to have a cesarean because I had bad blood. Other moms who say they went to the clinic for a normal prenatal visit and then their blood pressure was measured really high and they were rushed to the hospital. So some moms seem to have a better understanding of really what happened medically and others don't. Yeah, I think really more of a, you know, nothing but a kind of perspective survey in the community would give us that type of information. And then especially as compared to what other mothers who give birth in that hospital experience, to know how much of that is just the medical system and how much of it is racism directed explicitly against these mothers.
Great, thank you. Does anybody else have a question or any follow-ups? I don't see, we have a couple minutes. A lot of thank yous and great jobs.
Thank you to all the
Okay.
attendees.
Okay, well, super. We can end on that note. Thanks so much again, Melanie. It was great.
Thank you, everyone.
Appreciate your time.
Enjoy your weekend. Stay safe, healthy.
Thank you. Yeah. To everybody, yes, thank you so much for coming. We'll see you next week. Take care.